Okay, so it is 7:04. We will get started. Good evening all to the weekly huddle, session 57. My name is Anoop Agrawal. I am a cardiologist at Care Hospital, Banjara Hills. I am joined in today's session by my colleague and co-host, Dr. Praneeth Polamari. The huddle is an unscripted audience level interaction addressing common clinical scenarios that we encounter in our daily practice. We typically pick up a topic and or a clinical case like today's, and then we try to restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussion to a more organized platform like this one and share our ideas. While we do welcome the science and guidelines and whatnot, with this huddle, we intend to help a physician translate what is established knowledge to clinical practice, taking local factors and practice patterns into account. This is not a speaker and audience model, rather a casual interaction, which means any of the attendees can raise their hands and unmute themselves if they have something to say or something to add. As a courtesy, you should please wait for others to finish their thoughts before you unmute yourself. We host this session every Wednesday at 7 p.m. And while I say 7 p.m., we end up starting at 2-3 minutes late because people keep joining as the time passes by. Okay, so we have been doing it for more than a year now, and this is our 57th session. For today's session, I have the case, the details of which I have listed in the chat box. I will read it out, and I will start with my co-host Praneeth's opinion first, and then we'll go down the list of our attendees. So before I talk to you about the case for today, I want to share with you a similar case. Although we are not going to discuss about that particular case, we'll discuss about the one that I have shared in the chat box. So last month, there was a patient who was admitted to us, young guy with acute pancreatitis. And his triglyceride were more than 2000. If I have to remember the numbers correctly, they were about 2500 or something of that sort. And by the time he came into us, there was a series of basically hospital visits the guy went through, finally landing up to us. By the time he came to us, multi-organ failure was setting in, acute renal failure, and then gross pancreatitis on CT scan with pretty much involvement of surrounding organs as well. There was no discrete necrosis that one could identify. And then this guy was tachypnic, ARDS, and all those things. We, other than doing supportive management, we did plasmapheresis on him, 2 sessions, which did bring the triglyceride down. The patient unfortunately struggled for a week with us, finally succumbing to the illness. So we realized that this was an undiagnosed hypertriglyceridemia for this patient. And when we discussed about patient's family in terms of their family members and everything, quite expectedly, none of them had ever got their lipid profile tested. This to us was a preventable illness, but unfortunately, the patient succumbed to it. And what we realize is that this is this kind of illness, this is far more common in our practice than what we think. And I think that we need to have a systematic discussion in terms of what we would have done if this patient would have come to us, let's say a month or 2 months before, to prevent a situation like this. So what I will discuss today's case, this is a different patient. This patient, I didn't see him in the OPD. He is a friend of one of my cousins, and my cousin called me regarding this case. So I have not physically seen this patient, but the clinical details I have, which we can discuss on. So he's a 46-year-old male. He lives in a small town in Uttar Pradesh, and he is a local wrestler. Those in Hindi we call it Pahalwan, in his local area. And he came to his general physician for a routine checkup. He didn't have any obvious problem. He's a 46-year-old guy, minds his own business, runs a shop, and is athletic, as to speak. At the time of his initial presentation, he was noted to have a weight of 88 kilograms, and his height is 5 feet 10 inches, making it a BMI of 27.8. And he's pretty much muscular for what he does. His lab parameters, including hemogram, renal profile, and other screening parameters, they were all normal except the lipid profile, which I am telling you the numbers. The same numbers are there in the chat box as well. His total cholesterol was 248. HDL was 31. LDL was 33. VLDL was 133 and triglyceride was 667. So it was this triglyceride of 667 that caught his and the primary care's attention. It seems like nothing active was done to it. It was just noted that triglycerides are elevated. In the same setting, his liver parameters were also slightly deranged. SGOT was 54 and SGPT was 111. The upper limits of normal for both are in the range of 40s, like 44, 45, something like that. The rest of the liver parameters are normal. He also got his TSH and HbA1c done at that time. Those were also normal as well. So my cousin contacted me 2 weeks later asking, hey, listen, this is my friend and here is the problem and tell us what to do. So I wasn't quite sure of the lipid profile, how it was done, whether it was done fasting or non-fasting. So I asked them to repeat a study. So this study was repeated after 2 weeks. And this time I told them to be on an absolute fasting for 14 hours and then get the lipids checked. So the second set of values I'm telling you is a repeat sample after 2 weeks with 14 hours of fasting. Total cholesterol 267, HDL of 27, LDL of 33. They're all more or less the same as the first one. VLDL was 206. The first one was 133. And triglyceride in this sample was 1034. In the first one, it was 667. And this time also, the liver parameters were slightly deranged. SGOT was 49 and ALT was 98. So not 3 times the upper limit of normal, but pretty much close there. And this time I also asked them to get an ultrasound abdomen done, which showed grade 1 fatty liver, otherwise within normal limits. Rest of the abdomen was fine. He's asymptomatic. He's otherwise doing okay. So he certainly have hypertriglyceridemia. I think that with 2 readings, particularly with a fasting sample, I think the diagnosis of hypertriglyceridemia is made. And we can look into what kind of familial heritage pattern this guy has, which I did not delve into. There is, I believe, type 4, type 5, something of that sort. But the question here is, once you have a patient like this, how can we prevent this patient to have a similar fate, like I told you in the first case, how to prevent that kind of fate? And also, is there a ASCVD risk that this guy has, which we can reduce as well? So the points to discuss is how to risk stratify these kind of patients who have got very high levels of triglyceride, both in terms of cardiovascular risk as well as the risk of pancreatitis. What are the key lifestyle measures that we can address in these patients to tell them to keep their triglyceride level down? When to start drug therapy? What is our trigger when we think that now drug therapy should be started? Understanding that these particular patient has got some liver enzyme abnormality, and most of the drug therapy that we put has got a potential interaction with the liver function. And then choice of drugs in terms of statin versus fibrates versus omega-3s versus something else. So a lot of points to discuss, and I think pertaining to this particular case, let us hear our opinion. And then if we have time, we can probably have a little bit of general discussion as well. So Praneeth, I hope you got the case right. You were involved in the first case, unfortunately, which we lost. This case is doing fine. He's okay. How do we make sure he doesn't get in trouble? So Praneeth, your opinion on this?
Good evening, everyone. Yes, Anoop. So this case isolate hypertriglyceridemia undoubtedly. Triglyceride levels being high, asymptomatic. For me, regarding the treatment threshold, any triglyceride levels which are more than 500, I believe, patient has a risk of pancreatitis. And we have a reading which is more than 1000, which definitely puts him at a high risk of developing pancreatitis. So I would be considering starting therapy for him, if not for atherosclerotic cardiovascular diseases, but for the risk of pancreatitis. I want his I would like his triglyceride levels to be less than 500, preferably less than 250. So regarding start of therapy, yes, I would be inclined to start therapy. But the problem here is about starting therapy, which are fibrates, which are usually the drugs of choice for reducing hypertriglycerides. And with the deranged liver function test, starting them would be a problem. So this deranged liver function test, I would try to see whether these are something which is correctable or which is something issue. Like when we are talking about deranged liver function test, I would try to take the help of my gastroenterology colleagues if possible, and try to discuss with them and see whether this is something which is okay or it needs some more evaluation to be done in terms of liver function test. So hopefully, I would usually I would repeat the test after a month or so, make sure that his liver functions are okay. You said ultrasound anyway is fine, but anything like a chronic hepatitis or a recovering hepatitis or something is going on, I would try to check in with my gastro colleagues. And once LFT becomes normal, I would be interested to start them on fibrate therapy with a target of coming down to this thing. Now, when we talk about other parameters of how we can improve, obviously he's athletic, so the question of physical activity things probably doesn't are not relevant in him because he's quite physically active. So that anyway is continuing. What I doubt, I'm not sure, but with whatever knowledge that I have, or my myths or facts, I should say, is about these athletes, probably about their diet pattern when they try to build in muscle in the consumption of the foods which may be high in fats or those ghee or something, particularly the pehenwal and things, and probably some supplements to build up their muscle mass to which might also alter their lipid profile. So I would try to pay attention to their intake of dietary intake and any supplements that they are taking, which could probably contribute to their deranged lipid parameters. And mm, that is what I could think of. Any other questions that I can missing? I think I answered these questions. Yeah.
So Praneeth, the question here is, you would like his liver parameters to get better before you put him on therapy,
Yeah.
right?
Yes.
So
Yes.
how long will you wait? The nervousness is that, do you think waiting for a few weeks or few months is going to put him at a extra risk or a very high risk of pancreatitis or whatever?
So 1,000 is definitely something which puts him at a high risk of developing pancreatitis. At the same time, it's more like a chicken and egg situation where at one end you don't want to fire his liver, at one end you don't want to fire his kidneys. So yes, it is an impending threat of developing pancreatitis, but at the same time I do not want him to develop any liver dysfunction as well. So I would probably wait for a month or so, maybe 2 to 4 weeks, to closely monitor his liver function parameters. And if say things are still the same, I would probably discuss with my gastro colleagues and maybe start a therapy, and equally try to look at these other parameters which can change his or cause his deranged lipid abnormalities.
Perfect. Thank you, Praneeth. Let me go through some of my colleagues here and ask their opinion on this. I'm just going down the list. Dr. Srinivas Raju, if you got the case, could you please unmute yourself and share your thoughts?
Yes, Dr. Anoop, adding to what Dr. Praneeth has already said, this patient is a wrestler and probably is taking some diet, probably is on some steroids. We need to take that part of the history into consideration. And alcohol, probably we have ruled it out on a detailed history. Steroids, a lot of them don't come out with that history, but since he's a wrestler,
Sir, you are muted. Could you please unmute yourself? You just got muted, huh?
yeah,
Please, huh?
yeah. Steroids could be one of the reasons. Unless probed into, he wouldn't come out with it since he's a professional wrestler, and that is one of the common reasons why triglycerides could be high. And if we can get a urine routine done on him, sometimes some patients who have nephrotic syndrome, they have a high triglycerides, and certainly when the LFT is upper limit thrice the limit of SGOT, SGPT, we wouldn't want to start him on statins or a combination of statins and fibrates. I would still want to wait on the treatment part of it. Meanwhile, we can rule out the secondary causes like nephrotic syndrome or steroid abuse in this patient.
Perfect. Thank you so much, sir. I'll answer at least two things that you brought up. So steroids, we were pretty confident that he was not taking because he's kind of a friend. He's friend to my cousin. So his dietary pattern and lifestyle, we know a lot of it. And alcohol also, he absolutely does not touch. So at least knowingly, he's not taking steroids. Whether he's taking steroid in something that he's consuming that he doesn't know, that is something we don't know. But alcohol he's not taking for sure. And the point of nephrotic syndrome is well taken. That is something we certainly should evaluate. That did not trigger my mind. Dr. Chandramukhi, if you want to add something, could you please unmute yourself? Chandramukhi, madam, are you able to hear me?
Hello, good evening all. Thank you, Dr. Anu. Yeah, in this patient, like whatever Dr. Praneeth and Dr. Srinivas has said, I agree with them. And Srinivas has already brought out the points regarding steroid use and nephrotic syndrome. And also patients with uncontrolled diabetes with very high sugars, they are also known to have hypertriglyceridemia. So we have to check about that also. And regarding the therapy with statins, like we need to wait in his case for starting the statins because of the deranged liver function test. Thank you.
So that was my follow-up question. You would also wait for his enzymes to get better before you would start?
Yes.
Okay. Okay. All right.
And other options like niacin can also be considered in this patient.
No, it's not about considered. Would you start him on niacin at this time? That is the question.
I'm not sure about that.
Okay. Okay. All right. Thank you so much, ma'am. Dr. Praveen, if you could unmute yourself and share your thoughts, what would you do with this patient?
Good evening, everyone, sir. Sir, I have no what you call any thoughts regarding the management of this patient. I just want to know how would be he treated. My only option would be a phenofibrate, but again, considering his the unstable liver profile and all that, I want to just know what others would be how others would be treating this patient.
Okay, all right. So I think that I am happy that at least people are as confused as me talking about this case and how to start the treatment. See, the problem with the liver enzymes elevated in this case is that this could be just part and parcel of hypertriglyceridemia. Fatty liver, hypertriglyceridemia, and elevated liver numbers, they go together. So while I understand the apprehension, maybe treating, I'm just being a devil's advocate, I understand the apprehension, but maybe the early you treat hypertriglyceridemia better, earlier the liver enzymes may get better. And if we wait for the liver enzymes to get better without treating hypertriglyceridemia, maybe in this case, it will never get better. I don't know. I'm just kind of trying to give you both sides of the coin while accepting that even I don't know whether I should put him on therapy right now or not. Dr. Shankar, your thoughts, please, on this case.
Good evening. This is a very interesting case because in the beginning only we got an obstacle with the elevated liver enzymes. But this is a very, looking at the lipid profile, it is typical of Indian, South Asian Indian dyslipidemic dyslipidemia, where he has got a low LDL, lower average, low HDL, and high triglyceride levels. So when we get this type of hypertriglyceridemia, we may get such high levels of triglyceride in primary conditions like Fredrickson L1, type 1, type 4, type 5. They are familial conditions, but mostly they are seen in children or adolescents. But sometimes they may creep into adult age group also. And the secondary causes, as enumerated by our learned colleagues, uncontrolled diabetes, it's alcoholism, they are all ruled out. But hypothyroidism also we have to, but such a gross high levels of triglyceride may not be seen, but hypothyroidism also has to be ruled out. Anabolic steroids, because he is a wrestler, he might be consuming anabolic steroids also. That may be the offending drug also. We have to go into the details of the drug history. And high carbohydrate, junk foods, and all these things also, they come under secondary causes for the hypertriglyceridemia. So we have to rule out the secondary causes first, and we have to go for genetic studies to find out the cause for the hypertriglyceridemia, whether it fits into Fredrickson type 1 or type 4 or type 5. And coming to the treatment, because we are worried about these high levels of triglyceride, at any time he may land in pancreatitis, because the third most common cause for the pancreatitis is hypertriglyceridemia. First is gallstones, second is alcohol, and third is the commonest cause of third one is hypertriglyceridemia. If you don't treat it, he may land with pancreatitis earlier, what you alluded to. So fibrates, now our hands are tied because of elevated liver enzymes. How they behave also, once we put them on fibrates, we don't know. Niacin is because of flushing and hyperuricemia, even elevated liver enzymes. So we see with niacin, it is almost it's obsolete. So if it is available in India, Lovasa or Vescopa, that is icosapent ethyl ester. If you give 2 grams morning and 2 grams evening, 4 grams a day, because this is commonly used in abroad, in the US and UK. Whether it is available in India, or I don't know, but it is available. We can. It is available as Lovasa or Vescopa. We can get it, and we can start this icosapent ethyl ester in this case. And otherwise, if it is not available, meanwhile, we can use fish oil or omega-3 fatty acids to an extent of 4 grams per day.
Shankar sir, have you ever prescribed Lovasa in our patients in India?
That's what I'm telling. Yeah, this is the guidelines. They say that actually they in UK or USA they don't use fibrates also. They use only icosapent, Lovasa or Vescopa. We hear whether it is made available in India, I don't know, and how much it costs also, I don't know. But that is an option, because when fibrates, niacin, saraglitazole also. You see Indian diabetic, Indian South Indian Asians, with that atherogenic dyslipidemia, definitely we go for saraglitazole. That is a wonderful molecule, lipaglyn, in the market. I have got a lot of experience with this lipaglyn. We use it in a diabetic dyslipidemic patients. So if his liver enzymes are normal, I would have started even saraglitazole also.
So sir, saraglitazole also, because I don't prescribe that, it is not FDA approved. Is saraglitazole also cannot be prescribed when liver enzymes are deranged? Is that right?
Yeah, that's what, because it has got a dual PPAR alpha and gamma agonist. So that alpha activity is akin to fenofibrate, and the gamma activity is akin to this glitazones. So because of that PPAR gamma activity, Here we are not supposed to write because of the liver problem. Whether he has got a real problem, liver or not, this has to be investigated further.
Because saraglitazar is a Indian product drug, right? If I'm not mistaken.
Definitely. I've got a lot of experience with this molecule.
And do you know if this medicine is being used outside India as well anywhere, or is it exclusive to India?
It is actually it is being used frequently in Indian Americans, especially in Indian Americans also. They are using, but they are yet to be FDA approved. But a lot of literature is there regarding this saraglitazar. Though it is, because of it is a molecule of Indian nature, that's why it is not moving fast in the market. But otherwise, it is a wonderful molecule. But only the hurdle is it is a little costly. It is more than 20 rupees a tablet.
Right. And sir, you said omega fatty acid 4 grams a day. Do we have any such preparation available in India? Do you know of any such brand?
No, but that's why no brand is available. Only Cardian is there, but that is only 160 milligrams, I think. But fish oil we can use in that. Fish oil may be available in the market, in the supermarkets are there. We can use that fish oil instead of this Cadvian, this Merck company.
Okay. But for that, they will end up using maybe 10-15 capsules per day if they have to make it 3-4 grams, right?
Yeah. Well, that's very difficult to adhere with the patient.
Okay. And for people who have never consumed or heard about the fish oil, your patients will hate you if you tell them to take 10 capsules, because not
definitely they will.
Yeah, it's a bad smell.
Your friends and relatives, they never come to your.
Exactly.
Because it's a bad smell. Fishy smell will be there.
Yeah. Okay. All right. Dr. Vimal Abraham, you had something to add. Would you mind please unmuting yourself and share your thoughts?
I would like to agree with Dr. Anoop. I would not wait for the starting fibrates because the liver enzymes are only mildly elevated. It may be part of the fatty liver. So, and I will just do the viral markers, hepatitis B, C. If I rule out that, I will start the fibrates and I will repeat the LFT after 2 weeks. I don't think I will wait for, since the triglycerides are very high, more than 1000. I will not wait for the starting the fibrates. This is my point of view. I would like to agree with Dr. Anoop.
Dr. Vimal, since you are joining us for the first time, could you please just introduce yourself, 30 seconds? Who are you? Where do you work? Dr. Vimal, if you could just give us a quick introduction of yours.
Yeah, I am a physician and intensivist at Tamil Nadu, Dindigal, Tamil Nadu.
Perfect.
Fellowship Hospital.
Perfect. Welcome to the Huddle, Dr. Vimal, and welcome. You are joining us, I believe, for the first time, right?
Yeah, yes, sir. Yes, sir.
Okay, perfect. All right, welcome. Let us get going. We have Dr. Radha here. Dr. Radha is a dietetics expert. Dr. Radha, I think while he needs a doctor, he also needs you very particularly. How would you counsel this patient and the whole discussion about his diet pattern and what kind of therapeutic nutritional intervention that we can do to get his cholesterol levels down? Dr. Radha, if you could share your thoughts, please.
Thank you so much, Dr. Anoop. Actually, it's a very interesting topic. Just 2 days ago in my hospital, we had a patient who had triglycerides of 5,000. I'm seeing it for the first time. I always saw it around 1,000, which was not surprising, but He was at 5,000. And yes, he was on treatment. He was obese, had fatty liver on the similar grounds. But then he was normal. He was in the room, not even in the ICU. He was talking, he was eating well. So what we generally tell for these patients is initially we identify the oil intake, because this is something that we always want to do, because that's one component that we look at in controlling during uh, probably pancreatitis. If it is identified, most often yes, that is what we look out for. And so we look at the oil, we look at the composition of saturated fat, in fact how much of carbohydrate is he having, because that's most essential for us, which we do. And being a wrestler, probably he's loading himself with energy, saying that energy is required, and probably a lot of carbohydrate along with maybe a high protein diet also. Of course, not to rule out the use of steroids in them, because I do have many patients who say they are into such kind of activity but are on steroids. And of course alcohol, because both are not there is what you confirmed. So we look out for what is the medical treatment. But overall we bring about say a high fiber, a low fat, and a balanced diet. We kind of cut down fatty liver. Always has a link to we always tell them that probably their fat percentage or the total fat content of their diet is high, and that is what we control. And he being a wrestler, he has good muscle build probably, but then we have to wait against his composition also, diet composition. That's what we generally do. And in such patients, I know it is less compared to the 4 grams which Shankar sir did tell, but then I do give mega 3, which is around 180 130 composition of DHA and EPA. So that is what I give them. I prescribe omega 3. I do prescribe vitamins, minerals to most patients who come to the hospital with my review. But then this is what I generally do.
Ma'am, few questions. When you prescribe them omega-3 capsules, how many per day?
2 or sometimes 3 if they can tolerate. Yeah. So this mega 3 is something that I commonly prescribe. I know I'm using the brand name, but then this is what I generally prescribe, because I feel that has the best composition in the Indian brands, affordable, and 3 capsules per day.
And are there any nutritional intervention that you do in terms of taking certain things?
When they stay in the hospital, in fact, if they are there in the hospital, I put them on omega-1. It's an IV. Yeah, it's an IV omega-3 fatty acids, but then I put them on omega-1. That's an IV.
Right. And while we talk about what they should not eat, is there something that you would suggest what they should eat to get the triglyceride down?
Basically, they have to cut down the calorie intake. That's
calorie.
Okay. Yeah, and then I cut down the carbohydrate too. The usual that I point out most often, see, most of the times the carbohydrate that I plan my diets is around 50%. I don't go to the traditional Indian recommendation of 60% carbohydrate, but it's around 50%. So in such cases, I get it down to 40%. That's another.
Right. And then one last question. So because I
change the kind of protein for them. If it is a non-vegetarian source, then yes, I do cut that non-vegetarian. Say most of the time it could be mutton or chicken. I say no to mutton. Chicken, I reduce the number of times. I say you take fish and then put them on a whey protein. Temporary.
Okay. And what is the rationale of that, changing from animal? Mutton we understand. What is the rationale of putting other animal proteins to? I'm a vegetarian, by the way.
Saturated fat. No, I want to reduce the percentage of saturated.
Okay. So,
and they aim at eating 120 150 grams of protein per day wrestling. So that kind of protein. So if you can reduce it down temporarily to get down the triglyceride, it actually works.
Okay. And then, you know, because I had the privilege to engage in discussion with this patient for a long period of time over the phone, the only thing I could find in the diet which I thought was troublesome was the consumption of ghee, because in the villages, people have this thought that ghee is what gives them energy. What do you think of ghee in this regard? Do you think they should cut down completely, or is it okay to consume?
Zero. I put them on zero.
Okay.
Yeah.
So that and that part is clear.
Most patients who come to me, I know it's wrong, but then see what I tell them is if they have a traditional habit of consuming ghee, I say it has to be within the recommended quantities of oil. The recommended quantity of oil for a person, visible oil, this is visible oil, ranges between 20 ml to 25 ml per day. Okay, this is the recommended, but I cut it down to 15 ml. Of that 15 ml, it means 3 teaspoons. 3 teaspoons, I say, you can take 2 teaspoons of regular oil and 1 teaspoon of ghee if you cannot let go. Otherwise, please cut it down. I am a very bad person about when it comes to ghee, because I always have this composition in mind and say it's the first source of saturated fat. So I let it cut because of the Indian practice or patterns, dietary patterns.
Well, there is a lot of emotional sentiments right now in terms of ghee, and I think there is this whole push towards consuming ghee in this regard.
Actually, it is cow ghee.
Yeah. How about other source of saturated fat like coconut oil or palm oil?
I stopped peanuts also.
Okay.
Peanuts is another. You know, it's become a local, or it's become a very trendy thing saying that, you know, I'm eating bread and peanut butter. But then we have to remember that our genetic threshold for saturated fat is very, very low. So we can't be mimicking the Western saying that we can eat. See, they do tell us that yes, peanut butter is good, but then we cannot tolerate it so well. And that's my experience. Okay, this is my experience.
Right. And then how about other saturated fat like coconut oil or palm oil?
Coconut also I don't. I never put my patients on coconut oil because yes, I have come across many. I'm sorry, but many a number of cardiologists. I'm sorry, okay, who say that coconut oil works. But then yes, that's probably because of the MCT. But then you have to remember that 60% of it is saturated. Again. So again, I say no to it.
Right. And then one last question that came in the comment box is that whey protein apparently is often mixed with steroids. Is that true? And how do we differentiate that?
You have to go in for a standard thing. See, nowadays, FSSAI has really done a fantastic job of, this is step ahead, one step taken to regularize enteral nutrition for patients. Because, see, we have this problem where food is categorized as food, and enteral nutrition supplements are also categorized under food category, and they're not under medical category. So FSSAI has taken this step and said that certain products which can be used for enteral products as enteral products are going to be categorized as medically, so that it is claimed under insurance. Because when it is categorized under food, it cannot be claimed. So for this reason, we have what is called as FSDU and FSMP, food for special medical purpose. So they have whey protein which have been regularized, and they are medical products made under certain stringent standards. These are the products that you have to go. You go into any, over the counter, across the counter products. Yes, there is a possibility. If you go in for local products because it is cheaper, then there is a possibility. So standardization is something that we have to look at. But not all whey protein products have steroids added.
So, ma'am, help us out with this. If we have to prescribe whey protein to a patient, what should we write in our prescription pads?
Yeah, if you have to see, again, see, I'm branding, but not necessary. It does not really circle around to that. See, we do have an FSMP product, food for special medical purpose. Okay, there is FSDU, that is food for special dietary use, which you can get across the counter, food for special medical purpose. That stamp will be there on the tin given by FSSAI. Cabipro is one, which is a part of Fresenius. Okay, that's a 100% whey protein product. Does have carbohydrates, but gives 5 grams of whey protein per scoop. So you decide how many scoops you want to give. That is when you have intact protein. When you want a hydrolyzed protein, peptamen is one of them, but it tastes little like medicine because it's a hydrolyzed protein, but that's again 100% whey and a fantastic product. You know, I'm actually a fan of peptamen. I tell them that it is bitter, but then yes, my patients do have it.
Perfect. Thank you so much, ma'am. Let us get down our other attendees. Vrinda is here. Vrinda is an endocrinologist. Vrinda, help us out with this whole hypertriglyceridemia, particularly saroglitazar and any other medications that you have prescribed, and how do you see these patients?
Hi everyone. So usually I tend to we do see a lot of patients with hypertriglyceridemia, especially because a lot of patients with diabetes, insulin resistance. So so if a patient walks in, and not particularly talking about this case vignette here, but from endocrine standpoint, we're looking at their thyroid, their blood sugar control, diabetic control, PCOD, use of any medications, antipsychotics, birth control medications, estrogen use. So usually, if they're anywhere between 150 to say 500 and so, I am usually trying to control their blood sugars, or their thyroid, categorizing it as more mild to moderate kind of severity. I think more than 500, I tend to get aggressive. So for patients with triglyceride levels more than 500, the risk of pancreatitis starts climbing up. So I usually will start them off with a statin plus fibrate. And, I think as in the vignette, mild LFTs, derangement, the numbers like cited here, most consistent with like fatty liver. I am okay with starting, a statin drug in combination with fibrate. So the most commonly used in India is fenofibrate. I have used gemfibrozil in the US, but not so much here. I have never used omega-3s. I think when I was in the US, omega-3s would have been my go-to prescription after a fibrate. As Dr. Shankar already mentioned, 4 grams per day. But in India, I have actually not seen the medication being used, or I think maybe my information is less clear on its availability, but I think people made it clear that it's probably not available. So a lot of people get their over-the-counter omega-3s. I'm okay with them taking it, but for me, it doesn't meet the dosage criteria of 4 grams. So I usually don't pay a lot of attention to it. Coming to lipaglyn or saroglitazar, so I recently started using this molecule. It was not available in the US till the time I was there. And very recently, I think there was also a case of pancreatitis we treated. Similar case where I think LFTs were a little deranged. So I did a little bit of reading, and there was some reviews and some case reports which mentioned that saroglitazar could help improve fatty liver changes, and could be used in a NASH kind of a picture. So we actually started saroglitazar in that patient. So more commonly, as I'm studying about this drug and using this drug more often, I've started using it for hypertriglyceridemia patients. Works well for, especially the kind of population I see, diabetes, along with like deranged lipid profiles, especially HyperTG. So I like for this patient, if given a chance, maybe I would have considered using saroglitazar 4 milligrams a day for this patient, in addition to starting a fibrate.
Perfect. Thank you so much. And I must remind all the attendees that if you have any questions, comments, or suggestions, you can either raise your hand or unmute yourself to share your thoughts. or you can simply just write it in the chat box and I will read your question aloud. So either way, it is fine. While you gather your thought, I'll continue my discussion. Let me have Somaraju sir to share his thought. Dr. Somaraju, I hope you heard the case and all the discussion that came by. How would you manage this case, or if anything else you can add to our today's discussion?
Actually, most of the issues are very well covered. Particularly, Dr. Radha pointed out a lot of things, and others. Dr. Shankar also brought out a lot of the recent developments and how he tries to treat it and what's happening. In the newer drugs that Dr. Shankar mentioned, there are some recent evidence from the trial, clinical trial, that it was not of great use. While saying that, my preference would be I will start with only fenofibrate and not add statin to begin with. Because the combination of statin and fenofibrate produces more side effects of muscular as well as other symptoms. And I would avoid gemfibrozil and statin combination. I never try to use it because it's the most toxic. Chance of toxicity are very high. So I would start with fenofibrate. Most of the time it does work along with dietary modifications. And then say another thing, if somebody is a wrestler, as you said, and one must also recognize that there is a variety of gastrointestinal manifestations related to exercise and gastrointestinal symptoms and gastrointestinal manifestations. Post-exercise, there is intestinal ischemia, particularly after food. And particularly somebody is an athlete or this one, they don't tell you fully, as Dr. Radha said, and they take a lot of soft drinks. They are very high glycemic index and increase these triglycerides, etc. You have to go into details of their dietary patterns more than once. And one useful question to ask is to ask them to tell you their typical day, typical week, what they do, what they eat, what exercise they do, what else, how much they sleep, etc. And that gives you more information. And if they didn't give you much information, it will be available in second visit or third visit. So again, re-emphasizing, I will go with fenofibrate and wait for the response. Take his all the lifestyle considerations and most importantly, diet. Thank you.
Thank you so much, sir. Dr. John Jacob, you have something to add?
Sir, John, family physician working.
Dr. Jacob, your voice is very faint. Could you please come close to the mic and speak? Thank you.
Sir, my name is Dr. John, but I'm a family physician working with Dr. Bimal Abraham at Christian Fellowship Hospital, Ottanjatram. Am I audible, sir?
Yes, Dr. John, you are audible. You are a bit faint, but that's okay. We are coming close to our speakers. Please go ahead.
My BMI is around 25, 26. Around 5 years ago, my triglycerides were 900. I just want to share a personal experience.
Please do. Please do.
John, you're not audible. John, you're not audible.
Sorry. One thing is to look for family history. Any triglycerides in other members of the family. Rule out familial hypertriglyceridemia. Second is even though my triglycerides were 900 plus, I was advised diet and exercise for a few months, and after that, after 3 months, my triglycerides came to 450. And in spite of that, I was advised to take fenofibrate, and I've been doing that for the last almost 7-8 years. I've tried to stop in between. Once I stop, it goes back to 800. Once I'm on it, it comes down to 125. Yeah, just wanted to share my personal experience without statins, only fenofibrate and diet and exercise.
So, Dr. John, I'm glad that you're sharing your experience. If you don't mind, I'm going to ask you a few follow-up questions about your case.
Yes, sir.
Of all the risk factors that we discussed today about lifestyle and risk factors in terms of comorbidities and whatnot, would you mind sharing anything that you have that you changed or you didn't fit into any of the risk factors that we discussed today?
My BMI was around 25, 26, so no obesity. Weight is around 65, and not a diabetic, not a hypertensive, no other comorbidities, no family history, and none of my siblings also. No one has increased triglycerides. Anything else, sir, you would like to know?
Did you go for a genetic analysis like Dr. Shankar was alluding to in one of his discussion?
No, because none of the others had any triglyceride abnormality. I didn't do that, sir.
Right. Perfect. And okay, that is pretty good. Thank you so much. And Dr. John, one question that Dr. Radha is asking: how about the oil? What oil are you consuming? Are you taking too much ghee?
No ghee, regular oil. We are a family who very rarely, probably a few times a month, we eat non-veg. Otherwise, even prior to the triglycerides and even now. So oil has been not very, not a ghee. Rarely, I hardly use ghee.
Perfect. Thank you so much. And I really appreciate Dr. John for coming out and sharing your personal case. It really adds value to what we are doing and a little bit of personal touch as well. And it certainly takes a little bit of effort for you to come out and discuss about your health. Thank you. Really appreciate that. Dr. Praneeth, one last question before we start winding up today's discussion. We talked about hypertriglyceridemia and acute pancreatitis, but what we didn't touch upon is, are these patients at higher risk for atherosclerotic cardiovascular disease? And if yes, what do we do about it?
Yes, Anoop. So hypertriglyceridemia has been found to be having association with atherosclerotic cardiovascular disease, which we discussed in our one of these sessions, where we said yes, the association is proven, but the correlation of reducing triglycerides and reducing the CV events is what was not clearly established. But yes, we need to pay attention that it is associated, and equally the component of looking at the non-HDL cholesterol, which are these parameters which equally contribute to atherosclerosis, which needs to be taken into account when we read the lipid profile. And not only the numbers that are given, but sometimes it's mentioned, or sometimes we need to calculate about the non-HDL cholesterol, which equally contributes to. So for him, though the numbers are high, the attention goes more in terms of the risk of or immediate risk of pancreatitis, and probably as the duration goes on, equally the risk of ASCVD as well.
And when the ASCVD risk is high, do you think fenofibrate enough is good, or you think that we should be putting them on statins as well?
Yes, he should probably also be taking statins, according to me.
Dr. Anoop?
Yes, sir.
I forgot to add, if somebody is a wrestler, it's better that we also suggest to him whether he can change his profession if it is not a professional wrestler, or avoid wrestling, because abdominal injuries do precipitate in these patients pancreatitis, and injury to pancreas can occur, and keep that in mind. And then statin, again, I would not add statin straight away. In follow-up, the LDL, I'll go by LDL cholesterol.
Perfect, sir. I think that point is well taken. And in fact, I must say that I never thought of physical injury as one of the precipitant of pancreatitis. This is certainly interesting. And secondly, even in this patient with elevated non-HDL, your point is absolutely well taken that we definitely should start with one, which in this case would be fenofibrate. Omega-3s can be started in parallel, I believe, and then follow up with few weeks or month, and that follow-up can be debated whether we wait for few weeks versus few months. And if the numbers are still not to our mark, then a statin can be added later on. And hopefully by that time, the lifestyle can be modified and other things can also be taken care of. So absolutely point well taken. Starting two medications is probably going to be a little bit more riskier on him. And I also concur the point that gemfibrozil and statin, those days are gone. When we were talking about gemfibrozil, too high risk of drugs, and I think that those things we should really be avoiding. Praneeth also mentioned about the first session of triglyceridemia in our huddle that we discussed. About a year ago. I have shared the link in the chat box, and I've also shared the link of our WhatsApp group as well as other videos that has been posted or uploaded online. So if anybody wants to take a look at it, they can. The first session of triglyceride that we discussed, we mostly focused on ASCVD risk rather than pancreatitis. And this one we are focusing more on pancreatitis. So I think this kind of completes most of the discussion that may come across around hypertriglyceridemia and what we should do in our regular day-to-day practice as compared to what we read in the textbook or whatnot. So I think that's pretty much for the discussion. If anybody has got any questions, comments, or anything to add, please feel free. We will be online for the next 1 minute or so. So if anybody has got any questions, they can share, or any ideas as well. And while you gather your thought, I will ask my co-host Praneeth for his final comments for today's session. Dr. Praneeth.
Yeah, no, as you said, the discussion of hypertriglyceridemia is kind of good, where the earlier session was talking more in terms of ASCVD and this was more in terms of pancreatitis, particularly with the experience of the previous case which we had. So the thoughts of looking for the secondary evaluation of secondary causes of hypertriglyceridemia, including the importance of diet and the points of Radha given about the diet importance and about the cutting around carbohydrates and the highlighting the importance of soft drinks, etc. is very good, and it is thought provoking. And the usage of newer molecules like saroglitazar, knowing with the experience of Dr. Shankar sir about usage of saroglitazar and Vrinda also adding to that was good. Probably these molecules should be used more frequently, which probably can help the patients control their triglycerides. And yes, the mild derangement of LFT could be part of a fatty liver. So the comment which was given on starting and repeating LFT on after 2 weeks is also good, and re-looking at other cause of hepatitis like viral hepatitis, etc. was a welcome sign. So I think it kind of gives an overview of managing hypertriglyceridemia, and we can probably better counsel the patients when we see them next time.
Perfect. Thank you, Praneeth. If nobody has got any other comments, I'll just add some closing lines. Dr. Shankar, you are unmuted. Do you have something to add?
One thing I want to bring it to the house. See, in many other labs, only 3 parameters will be done. That is the total cholesterol, high density lipoprotein, HDL, and triglycerides. These 3 parameters will be done, and rest, that is LDL and VLDL, will be calculated from these readings. For example, if they want to get the VLDL, they will divide the triglyceride level by 5, so that they will get this VLDL level. Then LDL level they do by adding HDL and VLDL, then they minus from the total cholesterol, and they will give the reading of LDL. So ultimately, the triglyceride level will be the factor which gives these readings. So is there any lab, even in Hyderabad or anywhere, they do only LDL alone, or not deducting from the already available values, or VLDL directly? That's what I want to know from the house.
Yeah, so sir, I can answer that question. In fact, I was very pleased when I relocated back to India. What you are suggesting about the LDL calculated values, I was surprised to know that it's a standard practice in the labs in the United States. You actually have to write that please measure LDL. Otherwise, most of the standard labs in US as well, they do calculated LDL. Versus in India, I have noticed that majority of the good labs here, standard labs, they do measured LDL in most of the scenarios. So the whole idea of fasting lipid profile to get an accurate LDL in India, we don't have to worry about it. Majority of our labs, for my understanding, and I'm talking about standard labs like, you know, corporate hospitals or your standalone lab chains, most of them, they are measuring LDL and VLDL. They are not calculating. So the whole rationale of sending patients for fasting in India, at least, we don't have to worry about it. This was a pleasant surprise for me when I came to India. So for all the colleagues over here as well, I think this is an information I verified with multiple labs.
Dr. Anoop?
Yes, sir.
Can I add something here?
Yes, sir.
Even if they are not calculating, they are measuring LDL particle sizes, and LDL particle sizes has a spectrum. And so considering the particle size, none of the existing methods of what the laboratories use across are reliable. You have to, but the other methods that are possible, NMR spectroscopy, ion separation, they are too costly and difficult to put it into practice at this stage. So we are, say at the most, we are approximations what we measure. You should be aware of it.
Thank you, sir, for bringing this out. In fact, I deliberately I was trying not to touch that point, then it becomes too complicated. So basically, what sir was trying to say, and I hope it adds some value to the attendees here. Whenever we are talking about LDL, remember, LDL is a particle and cholesterol is a part of LDL. So in the lab assessment wise, either you can count the total number of LDL particles and measure it as total number of particles in your blood, and you assume that in LDL you have a certain percentage of cholesterol, and that's how you report LDL cholesterol. That is one way of doing it. The other way of doing it is you actually have an assessment where you measure the actual cholesterol content inside the LDL particle. Now you are measuring the true cholesterol level, which is there inside the LDL particle. So that is second way of doing it. And depending on what labs are doing, it starts getting too complicated to understand which of the methodology labs are using. Are they doing a particle count and then giving you a cholesterol estimate, or are they actually checking cholesterol level? And there it becomes a little bit more complicated to understand how these two numbers, they vary, because there will be difference in the reporting. What Dr. Shankar alluded to was something even more basic, where they don't talk about LDL at all. They just get triglyceride level, and using a mathematical calculation, they tell you what the LDL level is. And that part, I think in the standard Indian labs, we don't have to worry that much, because at least they are measuring the LDL level. But whether they are doing particle count or whether they are doing the actual cholesterol measurement, that we don't know, and that becomes a little bit muckier to understand. So anyway, I thought we went too far into the lab assessment, but I hope this kind of adds a little bit of intriguing information to the attendees, and maybe you can show off this next time when you are talking to one of your colleagues. Okay, this pancreatitis case that I mentioned at the start of this discussion, we will be telling you the details of this case in our next newsletter, which we publish every 3 months. So the next newsletter will be coming on 1st July. I will make sure I share the newsletter with all of you, at least on a PDF. And that will have this triglyceride case that we discussed. Unfortunately, we lost him, but it gives some pointers that we have discussed today. And as I said, that most of our sessions are uploaded, so you can go to YouTube or podcast to access those. And you can also join our WhatsApp group if you want to participate in ongoing discussion after the session is completed. I really appreciate your time taking today more than 1 hour on a Wednesday evening. As I told that we do this session every Wednesday. We have been doing it for more than 1 year now. And if there is any topic that you think we should include in our future discussion, please email it to me or WhatsApp to me. And I will make sure I include at some point during the discussion. Thank you all for attending today. Good night, and we'll see you again next Wednesday. Thank you.
Thank you.